Greetings from Thangam Cancer Center. In this week's episode, we explore a fascinating case of endoscopic double stenting for dual upper GI obstruction. Our patient is a 70-year-old gentleman who 20 years ago underwent a truncal vagotomy with gastrojejunostomy for intractable peptic ulcer disease. Now he presents with total dysphagia to both solids and liquids. Endoscopic and imaging studies revealed a large ulceroproliferative mass involving the entire stomach, extending from the jejunal anastomosis up to the gastroesophageal junction. A biopsy confirmed it as a poorly differentiated adenocarcinoma, a very rare but devastating complication after TVGJ. Given his reluctance for any radical treatment, we opted for palliative stenting. There are many types of GI stents. The self-expanding metal stents can be either fully covered, partially covered, or completely bare. Partially covered stents are often used as they allow for some fixation, though fully covered stents prevent tumor ingrowth but can sometimes slip. Stents also differ in the way of deployment. We used a pull type stent here, which is more accurate, while a push type stents can tend to overshoot. We performed the procedure under general anesthesia. As you will see, the endoscopy revealed a large ulcerative mass beginning at the JE junction, causing complete luminal obstruction and extending into the entire stomach. After careful localization of the gastrojejunostomy, we struggled with guide wire placement. Initially, the guide wire looped in the proximal jejunal segment, but after readjustment, we successfully cannulated the distal loop. Negotiating tight malignant strictures can often be technically challenging. In such situations, fluoroscopic guidance and the use of pediatric endoscopes can be of great help. Careful dilation using Savary-Gillard dilators may also be performed when required, although this must be undertaken with extreme caution given the risk of perforation. Once the position is confirmed, we deploy the stent. These stents have 3 radio-opaque dots, and the idea is to center the lesion around the middle dot. After the first stent is placed, we used a blade as a radio-opaque marker to accurately place the second stent across the gastroesophageal junction. This blade indicates the distal-most extent of the second stent. The second stent is deployed in a similar fashion. And after both the stents are deployed, we rechecked with endoscopy and slightly adjusted the esophageal stent, that is the second stent, as it nudged the first stent. Once satisfied, we fixed the esophageal stent using a stent fix apparatus, and a follow-up X-ray confirmed both the stents were in ideal position. The patient was able to resume oral intake just 6 hours after the procedure. In conclusion, endoscopic double stenting can offer crucial palliation in patients with synchronous upper GI obstructions. With precise planning and careful deployment, we can restore oral intake and improve the quality of life even in the face of advanced disease. You have been watching Dissect from Thangam Cancer Center. If you have any questions or suggestions, do leave them in the comment section below. Thank you.